Syncope, Greek meaning is to interrupt. It is defined as transient loss of consciousness due to cerebral hypoperfusion, and it is characterized by rapid onset, short duration, and spontaneous complete recovery. Syncope is common symptom, accounting for around 1 to 6% of hospital admissions and almost up to 3% of emergency room visits. As they say, the only difference between syncope and sudden death is that in you wake up. That is one of the most impactful statements to describe syncope. To tell whether one must be sure whether he is dealing with syncope or syncope mimics like seizure, as there are a lot of confusion regarding discrimination of syncope versus syncope mimics. Now, why syncope is difficult problem? It is similar response to wide variety of medical conditions, so difficult to differentiate. Transient condition, so it's not easy to assess everything. Unpredictability is troubleshooting. Difficult to establish definitive diagnosis and can be fatal some cases. Social and economic impact is also there, and this slide is showing impact of syncope starting from anxiety and depression. It may force to change the employment also. This is a slide which is showing transient loss of consciousness and syncope. This classification includes syncope, epileptic seizures, and so on. Causes of true syncope, this is simplified classification: neurally mediated, orthostatic, cardiac arrhythmia, and structural cardiopulmonary. Unexplained causes may reach up to 1/3 of cases. The Framingham study, which covered isolated syncope, 3% of male and 3.5% of females were affected. Now, if we consider mean age of initial presentation, the male and female, these are comparable. In male and female, the similar prevalence were found up to age of 75 years, and patients with more than 75 years of group, the males outnumber females. Mortality, there is no significant difference regarding mortality in this study. There are several studies regarding epidemiological facts of syncope, and I am highlighting some extracts from different studies. In all studies, syncope was found to be common with similar incidence in male and females, has a prevalence of around 42%. Another study has shown that it is around 35%, with peak prevalence of the first episode between 10 to 35 years. Incidence increases with age, especially after 70 years, and is bimodal with peaks at 20 and 80 years. Frequency varies from 15%. It's medical students in one study, they have shown it's around 39%, and in elderly it is around 23%. This slide, this is the same as I have told in previous slide. As patient grows older, prevalence of syncope increases. And after 80 years, it may reach around 20% per 1,000 individuals. Emergency department visits includes 3 to 5% cases. The hospitalization rate is quite high, and population-based studies have shown that patients with cardiac cause of syncope had higher 1-year mortality than non-cardiac cause. These are due to underlying cardiac causes and cardiovascular diseases. This is prevalence of self-reported syncope. Crude estimated prevalence came out to be around 19%. Prevalence was more in females. Median age of syncope was 25 years, and recurrent syncope were more in females. This chart is all about mean prevalence and their range of different types of syncope, starting from vasovagal, situational, and up to unknown causes. One point I need to highlight that the patients who were initially classified as suffering from syncope of unknown origin later found out to be suffering from cardiac causes of syncope due to meticulous use of ECG and particularly electrophysiological study. As high as 45 to 80% of those cases came out to be due to cardiac causes. In COVID era, the study was done and it was found that 4.2% was prevalence in syncope and pre-syncope in COVID patients. The most common variety was unexplained syncope, and so in COVID patients, presentation with syncope is not unusual. Recurrence of syncope is frequently high among patients with cardiac syncope was this study's conclusion. Now, Indian data, I didn't find many Indian data, but whatever I could gather, I am presenting here. Prevalence and 1-year outcome of carotid sinus hypersensitivity in unexplained syncope. This study shows the prevalence of carotid sinus hypersensitivity in patients with more than 50 years with unexplained syncope was high, more prevalent in elderly male and smokers. Carotid sinus hypersensitive patients suffered from recurrent syncope during follow-up. Permanent pacemaker implantation were needed in some patients, and they have advocated that carotid sinus massage should be a part of routine examination protocol for unexplained syncope. This is another study from India. They have been taken the patients with structural heart disease, LV dysfunction, although patients should have more than 30% ejection fraction and not in heart failure. Their EP study were negative, and the results were reflex syncope is the most common cause of syncope in those patients. Although syncope is not common in pediatric population, this study shows that commonest cause of syncope was neurocardiogenic syncope, followed by psychogenic, cardiac, neurological, and others. Epidemiological study depends on diagnostic yield. So this is all about yield of diagnostic modalities. And starting from history and physical examination, the yield is quite high in loop recorders and electrophysiological studies. So take home message, the syncope is a common problem that affects all age groups. Prognosis is generally favorable, but it can lead to mortality with significant morbidity, reduced quality of life, and burden on resources is profound. Proper diagnosis using appropriate tool like accurate history taking remains paramount. Technical innovation in monitoring and better understanding of provocative tests have greatly improved our knowledge and performance regarding management of syncope, but understanding of neurocardiogenic syncope leaves room for improvement. Further epidemiological studies will lead to better assessment and management of different types of syncope, particularly in our country. Thank you for patient hearing.